time to start kidneys, kidney stuff. So we're going to do chapters 54 and 55. This lecture will be on chapter 54, and it's going to start with the management of patients who have kidney disorders. Now, it is essential, if you are not familiar with the kidney or you can't remember it since anatomy and physiology, you need to go back and read chapter 53. Specifically, I want you to know on page 1509, figure 53.2, that's how the glomerular filtration rate works. And so when we talk about the GFR, that's what we're talking about. And I want you to remember how the arteries go into the glomeruli, down through the loops of Henle's, through the tubules. That's where all the exchange takes place of fluid and electrolytes and that kind of stuff. And I'm going to refer to that a lot, so make sure that you understand that process. Over on page 1508 is just a real, it's a good schematic and reminder of what the kidney structures and functions do. So I'd be familiar with that. Remember that normal GFR is about 125 mLs. That's important because when you go into the different stages of kidney disease, it is based on the GFR rate. So the other thing that you need to make sure that you understand are the normal values that we use when we're referring to the renal system, specifically BUN and creatinine. The other BUN, normal BUN, blood urea nitrogen, should be between like 8 and 20. Creatinine should be, it's low, it should be like 0.2 to 1.7, 1.8. Your creatinine is a much more specific indicator of renal function than your BUN. The other thing I want you to be really familiar with and remember is when levels go up in the urine, they're going down in the blood, and vice versa. And so when you hear the word like clearance, like for example, you hear the word a lot, creatinine clearance. That means how much creatinine is being cleared through the kidneys and into the urine. So as your creatinine clearance, as that decreases, that means you're going to have less creatinine in the urine, and it's going to rise in the bloodstream because creatinine and urea are excreted through the kidneys. So when you get more in the kidneys, you'll have less in the blood. So make sure when you're reading questions and reading lab values that you're understanding the difference between a serum, which means blood levels, and urine, which is any substance coming out in the urine. The other thing is that certain things should not be present in the urine, and if they are, it's also an indication that those kidneys are not working. For example, protein. You should not have protein in the urine, and when you do, it's called spilling protein, and that means there's a problem with the kidneys. Same thing with sugar. You should not have sugar in the urine, and so that's how you can tell somebody has like they're diabetic and how high their sugars are, because they'll start what we call spilling it into the urine. The other thing I want you to be familiar with is urine specific gravity and normal UA, urinalysis, because that's something that nurses, you'll get a lot. You'll get a urine sample, you send it to the lab, and you'll get UAs. So on page 1518 gives you sort of an example of what you're looking for when you're reading results of a UA. Urine should be clear yellow, pale yellow to regular. The darker the urine, the higher the specific gravity and the more dehydrated the patient is. The lower the spec gravity, the more pale the urine is, the more fluid the person has. So do kind of make sure that you understand what specific gravities are. Okay. The rest of that is all review, but if you don't know any of that, go back and review chapter 53. Now we're in chapter 54. A couple things I want to point out that you should know in the glossary that we're going to talk about. Acute kidney injury, AKI, is previously known as acute renal failure. Now they don't call it renal failure, we call it acute kidney injury because there's usually a precipitating event that's caused the kidneys to start acting up. And that's temporary. It doesn't, I mean, it can last up to a year, but it's not like chronic kidney disease that we can't fix. Acute tubular necrosis. I want you to understand that word because that has everything to do with the tubules that I showed you before, that other picture. And when those start getting, they should be nice and solid. And when they start getting holes in them, they get necrotic. Then you get debris and casts into the urine. And the specific gravity will be identical to the specific gravity of the blood, which is 1.010, because the blood and urine are meshing like that. That's called acute tubular necrosis. You need to know about that. Anuria and oliguria are both a reduction in the amount of urine. You need to be familiar with that. We're going to talk about AV fistulas and AV grafts. We're going to talk about azotemia. So I need to... Ryan, can you shut those doors really quick? Thanks. We're going to talk about azotemia. I'll be on there in a second. Azotemia is a high buildup of nitrogenous wastes in the blood, and that happens when the kidneys aren't working very well. We're talking about chronic kidney disease, and then you need to be familiar with the different kinds of dialysis. There's hemodialysis and peritoneal dialysis, and we're going to go into more detail on that. You need to be familiar with the word diacylate and effluents. Those have to do with peritoneal dialysis. I already told about GFR. Nephrotoxic is an important word because there's a lot of drugs and a lot of dyes that we give our patients that are filtered through the kidneys, and sometimes they can be nephrotoxic, meaning very hard on the kidneys. And uremia, but we're talking, uremia is like a buildup of nitrogenous wastes in the blood. Okay, so make sure that you familiarize yourself with those words. Let's just start with chronic kidney disease because it's really, really common in the United States. And I want you to look at chart 54.1 on page 1528 of your text. The reason you need to know this is because chronic kidney disease